Ma'am, we are in live, ma'am.
Starting off at 8 to 6 initially, and then gradually see how it goes. We are planning to have the OPD staggered on the days that we are operating.
Oh, good, good, very nice. I'm forced to start the meeting now because I think it's 6:30, and we'll try our best to keep it crisp and not drag it for long. A very, very warm welcome to one and all of you to our eye education webinar, which is really been taking a turning point at the way the attendance is coming up. And this time it's going to be on component corneal surgery, the future of keratoplasty. We are truly lucky. Dr. J.K. Reddy, you could come on screen. We are truly lucky to have Dr. J.K. Reddy with us, who's the director of the Shankara Eye Care Institutions and an extremely innovative surgeon, and a treat to have us as a part of a Coimbatorian. Dr. Sujata, I think she would join, but she is taking care of her daughter. So let us see. And we all know that she's another very prolific cornea surgeon from Rajan Eye Care Hospital, Chennai. We are truly lucky to have with us Dr. Sudhir. Dr. Sudhir, yes, Dr. Sudhir, who's a senior consultant cornea services, Shankar Netralaya, Chennai, a very, very essential part of cornea services, and also any software, any EMR, any doubt you have, he has magical thoughts to make it even more vibrant. We are truly lucky to have with us our beautiful Dr. Vanati, who we know is a professor of ophthalmology from the RP Center based at Delhi. But more importantly, now we know that she's the vibrant editor journal of All India Ophthalmic Society, and we are truly proud to see the kind of journey she's taking on. And moderating with me is Dr. Shreyash Ramurthy, who's going to take the lead. He's again consultant cornea, cataract, and refractive services at our Eye Foundation group of hospitals. And we shall, Shreyash, we would start with the debates. And after that, Dr. Rajesh, no, probably Revati, you have a meeting at started already, somewhere?
Yeah, yes.
So after that, Revati and then Dr. Rajesh would talk, and Amrita would also, once she joins in, but all the others are there to keep it energetic and going. And so we shall start with our debate with Dr. Bhaskar Srinivasan, who's now on a different journey, consultant cornea, and in a very brand new private practice, which is going to keep Madras even more feature for talking around. And he's going to be debating on DALK Big Bubble. I'm not making the introductions big because I would want you all to get to the content. And Bhaskar Srinivasan again is another veteran cornea surgeon of long-standing who doesn't need any description, is a globally famous person. And debating against him is going to be Dr. Vikas Mittal. And he would be telling us why he would prefer a manual DALK. And he's again cornea consultant at his Cornea Transplant Surgical Center, LGI Institute, Ambala City. Again, who is a very innovative surgeon who comes up with novel approaches in doing corneal surgery even better. So on to you, Dr. Bhaskar.
A very good evening, one and all, and thanks, Doctor, for the introduction. So I'll start with my talk. Is the slides visible?
Yes, visible.
Yeah. So the debate is between a big bubble DALK versus manual DALK. I don't think there's actually a debate, because you would need to be well versed in both, because it's, unless you're Dr. Fogla or somebody who's so well versed that he gets a big bubble in more than 90% of these cases, we probably have to have an understanding of both techniques. Having said that, I would probably opt for big bubble as the first choice of DALK, unless there is a contraindication to it. No financial disclosures here. Some of the photos or the videos would be from the time that I have managed patients at SN. So in fact, in terms of keratoplasty, we've started from lamellar keratoplasty to penetrating keratoplasty, and now we are back to a compartmental kind of procedures as such. And we all know the advantages that DALK has over a conventional keratoplasty. And the reason why a lot of us don't do DALK is because we feel it's tedious, it's time consuming, it's challenging, and you might as well get a PK done in half an hour's time rather than spend that extra 20 minutes, 25 minutes getting a DALK done. And the other thing would be reaching the correct depth or the interface, because if you are not deep enough, you will end up having interface haze, and that will compromise the vision. So for a best outcome, you probably need the deepest possible interface. You need the posterior layer of uniform thickness. You need a smooth donor and a recipient bed. The other factors in terms of coaptation of the edges, uniform traction of sutures, clean interface occurs both in big bubble as well as in manual. But when you're looking at these three first properties, deepest possible interface, uniform thickness, and the smoothest bed, that happens only with a big bubble, either a type 1 or a type 2. But a type 2, there's a higher risk of perforation. So we are probably looking more at a type 1, so that the risk of the surgery also reduces. So when you're looking at reaching the deepest interface with respect to DALKs, you have various techniques which have been described. And the most common is probably the big bubble and nowadays the groove and peel, which seems to be common. But manual is basically with respect to doing a layer by layer dissection. So you can see the video here, and this is a video almost about 10, 12 years back. We were using a needle and we can get a good bubble. And once that is done, we make a nick, a brave slash, and we are able to achieve a very smooth Duas layer, and the outcomes are good. So you have a very deep plane of dissection, you have a smooth recipient bed, and if you get a big bubble, the surgery is over in 45 minutes as fast as a PK. And you would probably get the best visual acuity and at the fastest rate that you can have with any anterior lamellar procedure. But the problems is the depth of placement of needle. We are worried about perforation, or we are, if it is too superficial, we get a stromal emphysema. Most of us are scared to make the big brave slash. And when we are dissecting it closer to the DM, we are worried about causing a perforation. With our better understanding and advances, we now know we can plan the surgeries better, so we can have a predetermined depth of the initial trephination. And anterior debulking makes sure that our needle is at a deeper plane. And instead of using a needle, using a 27 gauge blunt cannula reduces the risk of perforation during your insertion of the creation of the big bubble. Using a bit of Helon at the site of the brave slash prevents the immediate collapse, so you're less concerned with a DM tear. Also, marking the area, make sure that you are not left searching for your area of entry if your initial slash was very small. And the use of a visco big bubble to kind of make sure that it stays a little bit separated for your dissection. So all these have actually made big bubble a lot more safer and a lot more predictable and faster as compared to a manual dissection. So this is a recent video a few years back where you're using a predetermined depth knife. You're doing an anterior debulking to remove the stroma. So you're now sure. This is Fogla's dissector, where you're kind of creating a tract. And then with the cannula, you go in. Now, because the cannula is blunt tipped, you can go in more bravely, and you reach the paracentral area. And once you're there at the paracentral area and you inject air, there will be a formation of a big bubble in almost about 80 to 85% times, as long as you are deep enough. And the ease of your entry of your spatula tells you how deep you are. Once this is done, then you need to have a brave slash, which you can make either with a microkeratome, with angled MVR or with a 15 degree. And once that is done, rest of the surgery is over in no time. The only thing is, during this time, your BP is probably at the highest. That's the only difference between when you're doing a dissection of a manual dissection versus a big bubble, because you are bang on the Duas layer, you need to be even more careful. But there are some situations like this with the pediatric patient where we debulk the anterior surface. We tried to initiate a big bubble. We got a type 2 big bubble, which is basically more of a glassy bubble, and it is below the Duas layer. So because of the anterior haze, we are not able to make out, but you can actually see the whitish ring forming. And then you can actually see there is a glassy end. It's not like the white emphysematous bubble that you saw. So in these cases, you might probably be safer on to just do a manual peeling to make sure that you don't end up rupturing it. So like I said in the initial part of the talk, it's not whether you would want to do a big bubble versus whether you would want to do a manual, you would need to be well versed in both. And here we just opened up the plane, removed the air, and then did a DALC. So the advantages, again, to reiterate, is a smoother interface, a faster surgery, a best visual recovery, and a fast visual recovery. Obviously, if there are tears or scars in the DM, then they are not a candidate for a big bubble. And when looking at literature, there are various reports, right, in the initial reports where they said that, yes, a big bubble has a better visual acuity. There are newer reports which say that the visual acuity is almost similar, but uniformly, all of them say that big bubble DALC gives you a much faster visual recovery. And there are studies which have looked at even, say, less than 50 microns residual bled and said that the visual outcome in big bubble is slightly better than DALC. And the densitometry measures with big bubble is much better than a manual DALC, and the densitometry is almost similar to a PK, whereas that doesn't reach that same value in manual DALC. To conclude, big bubble is my preferred technique, but I would always keep manual DALC as a backup. Thank you.
Thanks, Dr. Bhaskar. That was a very crisp talk. Shresh, would you take, shall we finish the debate and then take the questions?
Yeah, we could probably take both together so that each pros and cons can be discussed.
On to you, Dr. Vikas.
Yeah, thanks so much. Can you see my slides?
Yes.
Okay, great, fine. So thanks so much. First of all, it's a fantastic platform. So what I'm going to do is I'm going to share my experiences with manual DLK. So I'll just I'll show you a few videos, few cases, and then I'll take you go through a few literature as well. So I did my first DLK in 2008, which was 2 years after my fellowship. And my first DLK, all of them had to be converted into PK, and these were all, I was trying to do big bubble, and I couldn't do all those things which Bhaskar has shown. And after that, I stopped DLK. I thought that I'm not a good DLK surgeon. In 2009, next year, I happened to visit Dr. Paras Mehta, who showed some beautiful post DLK post-op patients. And I asked her that, I'm finding a lot of difficulty in it. She said, Vikas, just keep this bubble out of your mind and you'll be able to do a successful DLK. Next year, I restarted DLK, and in the last 10, 12 years, I've done close to 80 DLKs, which actually is only 3.5% of total corneal transplants. And most of these DLKs has been manual DLK. This is how we do the surgery. First is that, the trephination, with trephine, I make only the mark, and then I use 250 micron fixed step knife to make that groove. Then remove the anterior stroma, the anterior debulking. This can be done very fast. And after that, the second layer is removed after we have decompressed it a bit. This fluid also tells us how much fibers are actually remaining. While dissecting the second layer, it is important where you are cutting. You need to cut these fibers which are attached to the flap, which I'm holding, and not at the stromal bed, that with attachment, so that you don't end up in having any perforation. Here, the speed becomes slightly slow. The third layer, it is easily visible that these fibers can be easily peeled off. So you are sure that you are in the posterior stroma, posterior stromal area. And after this, the same steps, the preparation of graft, remove that endothelium, desperate membrane from the graft, and then you place it with any suturing technique. I like 16 nylon sutures. The suturing pattern is absolutely same as PKP, just you need to ensure that the fold that you see, keep on pushing it after 4 sutures to the periphery, so that you don't see these folds in the center and doesn't cause any problem. You check, ensure that you have seen with your flaring Mallin's ring, and the surgery is over. So here are a few post-op patients. This is 3-week post DLK for keratoconus. If I zoom this photograph, see, it's hardly visible. This interface is hardly visible if you see even at 3 weeks time. So this is another patient of DLK for keratoconus. This was the first POD. It was quite edematous, which cleared off at the next follow-up, that is at the 4-week, and it was absolutely fine. So is it that all first POD of manual DLK looks like this? The answer is no. Another first POD of manual DLK, I think it depends on what is the graft thickness when you are starting. If you have a compact cornea, the first POD will look something like that. Even though that edema clears off pretty fast, this is 2 weeks post DLK, 5 weeks, 8 weeks, and when you see even the OCT, you have to really work hard to see where is that interface and how much stromal fibers are remaining. And if you are in, later, like 6 months, 1 year after that, it's absolutely difficult, very difficult to find out where is that interface. It's barely visible. Visual acuity, if the eye has a potential of 6x, it will reach 6x. 6x or 6.9. It is very, very common to see good vision after DLK patients. Yes, we do come across by some weird kind of astigmatism, like this patient had high myopia and high astigmatism, and we had to use a scleral contact. And sometimes you see those posterior DM folds if you have taking care of advanced cone, but this also tend to faint off, and after 6 months or 1 year, it doesn't cause much difficulty in the vision. Apart from K-conus, I enjoy doing it for corneal dystrophies, very handy for infections and scars where you don't know how deep it is. Initially, I never used to talk much about DLK, and the reason for that was I always thought the great DLK surgeon is the only one who can do a good big bubble DELK. It's only 3 years back when I had to present a DLK, I reviewed all my cases and found that the outcomes are pretty good. Rather, when I talked with the various surgeons like Dr. Rasik Bihari Vajpayee, my friend Rishi, my DLK guru Paras, most of them, majority of them are manual DELK. In fact, in India, only 1/3 of the corneal surgeons, they do a big bubble DELK. There has to be a reason for that. There are enough studies, as Bhaskar also mentioned, that where we have seen that both manual DLK and big bubble DELK, the visual outcomes are equivalent, whether it is a UCVA, BCVA, keratometry, astigmatism, all are equal. Yes, if you see the first 1 year, the visual acuity may be slightly better, but there are studies which say that difference is also insignificant. Another comparative study, people have studied hysteresis, reflectivity, densitometry, this all are same in both big bubble as well as manual DLK. If you have an inadvertent trephination, the manual DLK is lifesaver. You can still go ahead with DLK, don't need to convert into PK. In fact, so overall, if you think about any corneal, any complication in DLK as a trainee or as a learner, all those perforation, majority of them are out if you keep this bubble story out. So to conclude, for me, manual DLK and bubble DLK are two different techniques of doing the same thing. It's just like you have a stop and chop or four quadrant technique. And this manual DLK is a minimal learning curve. This surgery was done by my fellow first year into her practice, just out of her fellowship, and she could do a DLK. So if you have a PK skill set, manual DLK can be easily done. Predictability is very high. Last these 10 years, there were only 1 or 2 cases that I had to convert PK, because that also, scar was very deep. For DLK trainee, I think you can straight away go ahead with, do your DLK, manual DLK, see after 15, 20 cases, so that you can see your own post-ops, and then you can think if you want to really shift to big bubble DLK. I will leave with these 2 cases. The first case was sterile med, and the second was post-archiectasia. These kind of patients, manual DLK is the only thing which will help you to do a actual DLK. So in lower video, you can see I'm removing these stromal fibers piece by piece. So it's like a pizza pie, it can come out. And in the upper one, so the whole stroma is removed concentrically, manually, by step, and then you go ahead and do your routine suturing in DLK, and the results are pretty good. So thanks so much. This is all from my side.
That was nice, Dr. Vikas. Shresh, can you take the first question?
Thank you so much, Dr. Bhaskar and Dr. Vikas, for wonderful talks and videos. Always a pleasure listening to both of you. And yes, while the construct of this topic might have been a debate, not always it's actually a debate, and I'm sure all of us use both techniques interchangeably. While even those who are in favor of big bubble, I'm also one of them, but I would probably attempt a big bubble in most cases, and then if it's not successful, switch over to manual. And similarly, there may be some cases where with a very thin cornea, the last ones like a pseudocornea, which Dr. Vikas was showing, where we would obviously not attempt a big bubble and go for a manual. But first question to Dr. Bhaskar, is there any way where you decide any criteria that you keep in mind that this is an eye where I will try a big bubble first and then go to manual, or these are sets of eyes where I'll directly go for a a manual dissection?
I mean, unless there is a DM perforation, like a history of eye drops, kind of a thing, or it's an infection, we have glued it and it has then formed a scar, where we know there is probably a breach of the DM, where you don't want to do a manual, where you probably also want to leave a little bit of stroma in that area. So those are the only cases where I would not do a big bubble DALC. Otherwise, I would attempt it, like I said, and if I get it, I would go ahead with it. The advantage of attempting it is at least that stromal emphysema and the presence of the air in the deeper layers gives you a very good visible clue telling you how much of stroma is still there. That way, even if you're doing a manual DALC, then the Rishi's technique of groove and peel, where it's like almost like an onion, you can kind of keep going till you reach a plane where your instrument enters in very easily, or you're able to see the shining DM, and it kind of peels off, where you would probably not use the crescent. The only worry that I have with the crescent is invariably in the initial stages, you tend to have slightly different planes. And when you're doing a manual, the tissue feel is important. As you keep doing numbers, you will realize once you put your instrument or spatula in, the ease with which the spatula goes in kind of gives you an idea that you are still superficial or you are reasonably deep as such.
Wonderful, sir. I completely agree. And of course, attempting a big bubble also gives you that stromal emphysema, like you highlighted, which gives you a nice idea about how deep you are in your dissection. To Dr. Vikas, I mean, again, I've always known that you say that you directly go ahead with manual in most of these situations. And you do show some wonderful post-op pictures, ASOCTs, where, the big challenge, I think, for most of us when we think about manual versus big bubble is when we do a big bubble, we feel that your plane is obviously it's uniform. You cannot have variable amounts of thickness, and it's a very uniform plane. Whereas with stroma, the only concern with manual is, will we have differential thickness? If we have a uniform 30 micron, uniform 50 micron, uniform 60 micron, I think the visual impact is going to be less. Especially with keratoconus, where majority of our cases are keratoconus, having a very thin cornea in the center and a relatively thicker mid-periphery, how do you ensure that you are able to get a very uniform stromal bed like you are showing in many of your cases?
Yeah, Shreya's right. Even I had this thing in my mind, but practically it doesn't make any difference. If you see the cornea also, it's not that cornea is uniformly same thickness. It's not that it's 600 in the periphery and 600 in the center. It's not like that. So what I have felt that it hardly matters. So suppose in the center you have 50 microns and the periphery you have, say, 70 microns, 80 microns, hardly matters. And this particular differential, what you're talking about, suppose, when you see 6 months down the lane, 8 months down the lane, it's hardly visible because it's only 50, 70, 80 microns. And then you have this 600 microns thick cornea, right, which settles down. So it hardly matters. How do I make sure which plane I am in? If while you are dissecting, if you have seen the resistance, you are in the superficial. If your resistance goes down, that means you are coming the posterior stroma. Is the central 6-7 mm? If there you have got a good decent dissections, absolutely fine. There have been a few instances where I had perforation in the periphery, and where periphery, another side of the periphery was not dissected much, and I left. So differential was 50 here and 120 there. Even then, it doesn't matter much as far as that. So I'm yet to see a patient where I thought, oh my God, maybe I wish I would have done a big bubble here. So I think that practically that doesn't make much difference. And then it depends. If you keep on doing it, you get a hang of that. You know that you are in posterior stroma. You know that which area you are in. And then it hardly matters. Most of the times where you are starting from, that area slightly becomes thick. So you know that, this area will be thick. So you ensure that once you have taken out your third layer, there also you dissect those stromal fibers. But practically, I think clinically it doesn't make much difference.
If I could just add a point, Shreys.
Yes.
It's important also to have the verticality of the edges. Most of the time with DALC, you actually end up having a shelving edge, where again your graft house supposition becomes a bit of an issue, especially if you're doing a manual DALC and you still have a little bit of a residual tissue and you're using a therapeutic grade tissue because you feel your endothelium is not required. So that is significantly edematous, this bed is not as good. So you need to be very clear that you are able to maintain your anterior thing. So for that, the verticality of the edge is definitely important. And if you are deep enough, generally, even in the technique that Vikas showed, as you kind of peel off, you will really not need the crescent. You will probably be able to separate it even with a spatula, or it will actually peel off by itself. So if you reach a stage where it is kind of peeling off, then it is in the same plane, because your collagen lamella is in the same plane. That's why it is peeling off. So you will have a reasonable contour which is matching the periphery. It's only when you are cutting that you might have a slight difference with respect to the planes in the center as compared to the periphery.
True, I think that is very important. That's why in keratoconus, I always just mark it. It's not that we refine it, just mark it and then use this 250 or 300 microns to ensure that it is vertical. That is a very important point.
And the
Dr.
other thing was dissection. You have to be make sure that you are a hypotonic eye. You have to make sure that it is hypotonic. Otherwise, you'll end up with a perforation. Because even if it's a sharp instrument, if your AC is shallow, AC is shallow and the eye is soft, it will push the DM down rather than having an entry into the anterior chamber.
If there is
Very extremely valid points, sir, and both of you. Just a word for the audience. Although it is a debate, and if it were to looking at visual outcomes, at least a couple of large studies coming out of Italy, which have shown that when we compare a big bubble and manual dark at 3 to 5 year outcomes, they have shown that the visual outcomes are similar. The rapidity of visual recovery seems to be a little better with the big bubble than what we are seeing with the manual DALK. And I think that's kind of the experience of most surgeons present here, where we are doing both big bubble as well as.
So generally around 6 months would be the time frame. After 6 months, you would probably not have a difference. Even when you have left about 100, as long as the interface is not irregular, it is uniform. Even with 120 microns, you might end up with a 6.6 vision. You can think of it in terms of DSEC. Yes, some of them end up with 6.9, but some DSECs where you have 120 microns of stroma sitting there still ends up with 6.6 also. But the number that reach 6.6 is more with DMEC as compared to DSEC. Unless you are looking at ultra thin DSEC. So if your DALK residual tissue is less than say 70-80 microns, then it's kind of going to be similar. It's only a question of maybe a few months time that you would want to reach that best visual acuity.
True, Bhaskar, I think if you keep
the voice is breaking, sir.
Ultimately you reach a point so I think those kind of tissues, it hardly matters. Even in first week, first month, you will see that stroma is absolutely clear.
Supposing there's a lot of interface haze, when would you decide to do a PK or a repeat DALK, Dr. JK? You're muted.
Yeah. Interface haze, we don't get it after surgery. You get it before surgery. Already there is a high drop, something like that. Or a deep stomach scar when you are doing manual DALK, you are not able to remove, something like that. But post DALK interface haze is very, very, very rare complication. As far as unless there is a vascularization, not a follow-up patients are not following up, they might have lost or follow-up come back a few years. It's a lot of vascularization in the interface. That is the only condition we had interface case where we repeated the DALK and they're doing that.
Another potential area of, probably I'll direct this question to Vanati madam, that where manual we would prefer over a big bubble is in the case of active infections, when we are trying to do a therapeutic DALK as such, in especially Acanthamoeba, certain functions, infections which are still not reached the DM. What would be your suggestions on that, madam? How do we achieve a DALK in those cases with active corneal infection?
Thank you, Shreyas. I think the decision to do a therapeutic DALK is when the infection has become quiescent. So that's going to be your leading indication that you have controlled the inflammation to the maximum possible level here. So which means you're looking at a healing stage of the infection here. And you also do not want the posterior stromal involvement. So your infection needs to be contained within the anterior and mid stroma for an effective therapeutic DALK. But all said and done, I think the haze in a therapeutic DALK is always much higher than the DALK done for optical reasons here. So getting a 6.6 in most of these cases, even after your infection is well controlled, is going to be challenging here. You'll probably land up getting 6.18, 6.12 in the best of hands here. And I think both the techniques have their own plus and minus points here. And what is more challenging in both a manual and a big bubble DALK is the post-DALK astigmatism. I think astigmatism management is one thing which always tends to be a spoiler in a well-done DALK in both the scenarios here. And if that is contained and we take care of all those wonderful points which both speakers highlighted in a very nice manner, I think that is when I think after 6 months, it really doesn't matter what technique you have done, actually.
Thank you. So we shall, after a great debate, we shall go on to our next speaker. There's a little change in sequence because Dr. Revati has another meeting happening at the same time. And we are truly thankful, Dr. Reddy, there for making space for us. And she needs no introduction. She's the chief of the Corneal Refractive Services at Arvind Eye Care Systems based at Coimbatore, a very admired surgeon nationally and internationally. And she's going to take us on to relevance and importance of PK in today's practice. On to you.
Thank you, Dr. Chitra. My slides, are they visible?
Visible. Visible.
Are they visible? Can I go ahead?
They are visible.
Yeah, thank you. Thank you, Dr. Chitra, and also my co-speakers who readily accommodated my request. So this topic is about the PK. Is it relevant even now where the lamellar surgeries are taking over? And they have definite advantage in preserving globe integrity, and many problems with the sutures and others can be foregone, and also faster recovery with less complications. But why we need PKP even in this era? Because there are certain situations where PKP will be the saver. For example, in case of scar, which is a full thickness one, and also even post trauma also, where not only the scar, the visual corneal contour itself is compromised badly. And in case of dystrophies, where a combined anterior and posterior dystrophies. And in case of failed grafts, where we need to do this failed grafts, even still we can do a posterior keratoplasty, but still sometimes we may need to go for a PKP. And also in case of corneal decompensation with a compromised iris lens diaphragm, like in case of ICE or an aphakic eye or secondary IOL with a vitrectomized eye, in those cases, of course, it's quite true that whoever has seen Dr. Fogla's pictures, beautiful pictures in Keranet few days back in a post tube case, ICE will be, the hands will be itching to wait for next ICE to go for a EK only, a DSEC. But of course, for the beginners, we have to be very careful. If unless you are very well versed and you are very confident about your this thing, and also keep a cornea as a backup. At any time, you should be able to convert. Then you go for such heroic surgeries. And of course, it can be done, but of course, PK has a role in such cases. Coming to the dystrophies, in case of anterior and posterior, we can go for a ALK or EK. But in case of dystrophies like MCD, it's quite difficult to assess the depth because it can go up to the Duas layer. And you may need to, if you want to get a clear interface here, you may need to intentionally create a type 2 bubble here. and which is technically very difficult, and it can fail it can go for perforation or big tear where you have to convert. And another thing, if you are not able to remove all the material, then the recurrence may be faster in these cases. And remember, MCD can be associated with endothelial changes also. So in these cases, better to plan as a keep and PKP grade cornea and try, but if necessary, you have to convert to PKP. In case of other posterior dystrophies like CHED, the removal of the endothelium may be quite difficult. And if the cornea is too thick, again, just a DMEC or DSEC sometimes may fail. So you may need to convert them later to PKP, or if it is too thick, better to plan as a PKP. In case of regrafts, the graft, not only the opacity of the graft, if the graft is grossly decentered, then you may not get a very good, as Dr. Vanati put it, you may end up with, even after a good DSEC, you may end up with a very bad, ugly astigmatism. So it's better to plan for a regraft, well-centered, good PKP. And in case of post-hydrops, of course, if the scar is only in the posterior level, still you can attempt DALK, but if it is a full thickness, very bad hydrops, not managed properly or spontaneously resolved, we ended up with such a scar, then you may need to go for a PK only. In case of scars, we have to remember one thing, either in microbial infections or viral keratitis or trauma. As in this case, you can achieve some kind of closure initially, but later you may need to replace this cornea with a full thickness graft only, where the contour is really compromised. In scar, we have to be very careful, especially if the patient comes with a scar and you don't know why that scar occurred, and you have to really probe into it, at what age he started getting this problem, because amblyopia could be a issue in that eye. And the depth of involvement, of course, you can use ASOCT. In presence of vascularization, thinning, lipid deposits, and associated ocular surface problems also have to be kept in mind in preparing these corneas. Especially the corneal sensation is also very, very important. In case of vascularization, we have to address it first, either with cauterization or nowadays intraluminar injection of mitomycin, which again we have to be very careful, and we have to take it with very cautiously only, and control the inflammation. And in case of superficial vessels, look for any limbal stem cell deficiency, address it first, and then go for your procedure. And corneal sensation is very, very important, especially if it is anesthetic cornea. You are going to get into big trouble, either DALK or whatever it is. So you have to address this first and then plan for the surgery. If it is a scar due to the viral keratitis, you know the precautions. You have to cover it with oral antiviral also. And as a surgical intervention, you have to remember, this is an open sky procedure. And you have to address, as I said, the ocular surface issues, and starting from the lid and other conjunctiva and cornea, and also the intraocular issues, like a mobile IOL has to be removed, and you have to plan your secondary IOL, another scleral fixation or iris fixation IOL. All those things also you have to plan properly. Lot of imaging also you may need to do to plan your surgery. And remember, this is an open sky procedure. Some of the fellows may not, of course, fellows may be well versed with PK, but sometimes people, especially students, will get carried away. They think only lamellar keratoplasties are the keratoplasties. But when doing PK, we have to remember, this is an open globe procedure where you need not only complete akinesia, you need to control the blood pressure, intraocular pressure, blood pressure of the patient, as well as blood pressure of the surgeon also. Many times, we'll be really, it's testing surgery, and the speculum should be without any pressure over the globe, and whenever necessary, use the scleral rings. And this is a very, very old video. I think this is a video by Dr. MS. I'm not very sure. So here, why I want to show this, mainly like when it is open, till you put the graft again and suture, get that 4 cardinal sutures. You have to take care of your palpitation also. And you need, this is the time where you need a complete akinesia and complete control. This is very important. And of course, astigmatism, as in the case of DALK, here also astigmatism is a question. And like Dr. MS used to tell, Dr. M. Srinivasan used to tell, if you know how to put a good 10-O nylon sutures in those days, ECCE, without creating much astigmatism, then you can do the keratoplasty by yourself. You don't need any training. But I don't think it is that easy. And of course, PKP is also, penetrating keratoplasty is also used in therapeutic grafts to remove deload the infection. And also in case of patch grafts and any perforations, whenever you get a perforation, you can do this. The flip side, of course, the suture related problems and the rejection is a major issue. In EK also there is rejection, but relatively very, very less. So these cases have aggressive follow-up and close follow-up and aggressive management. In conclusion, this is not a last art, still it has a lot of role. And the corneal surgeon, all corneal surgeons should be well versed in PK, because at any time you may need to convert also. So you have to be well versed in this procedure also. Thank you.
Thanks a lot, Dr. Revati. On to you, Shreyas.
Thank you so much, madam. Very extensive talk. I mean, truly showing why PK is necessary in so many different scenarios, and it's an extremely important art that all cornea surgeons should perfect. A quick question about, you were showing a lot of situations where combined surgeries may also be a necessity with PK. How do you go about deciding in some of the opaque corneas whether you're going to tackle the lens in the same sitting, or whether you're going to do it in 2 separate sittings? And if so, any considerations regarding IUL calculations?
Yeah, of course, as you said, if we can use some of these imaging techniques to assess the lens status or something comfortably, then we may plan. But still, if it is completely opaque, then I would like to do only the corneal part, where we can get a good corneal surface, where we can properly plan the IOL power calculation, and we can do the lens part later. That's how I would prefer. Unless where I can see the lens, the opacity, or it is not in the center, it is towards the periphery, something like that.
Yes, ma'am. And, at least initially, we were a lot of, there was a talk about suture removal in penetrating keratoplasty versus lamellar, that you would do a little earlier in lamellar versus penetrating. Do you have any difference in your practice pattern, or do you treat both similarly?
I treat both similarly, even in DALK, because actually in DALK, I feel you may need to keep the sutures even longer than in PK. Because in DALK, it's tend to be like once you remove the sutures early, if you are going for early suture removal, there will be some myopic shift, and also the astigmatism can be more. So I treat them both in the same way only.
Wonderful, madam.
Thank you. Thank you, Dr. Revati. So we shall now go on to our next speaker, Dr. Rajesh Sinha, who needs no introduction at all. A very dynamic leader he's been for years in his tenure, and he's a professor of ophthalmology and a senior consultant, cataract, cornea, and refractive services from RD Center, Delhi. And he's going to talk to us about tackling astigmatism post-PK and DALK, I think, which is very relevant in course with the discussion now.
Thank you, Dr. Chitra and Dr. Shreyas, for this opportunity and allowing me to speak. We see that a lot of grafts that are absolutely clear, but still, I think earlier Dr. Vanati was talking about the menace of astigmatism that after DALK that sometimes causes suboptimal visual outcome. So even a clear graft can have a suboptimal outcome, and in a large majority of cases, it's basically because of astigmatism that is there. And this, there are few studies that I have mentioned. There are more than these many, and they have shown that nearly 15 to 31% of patients undergoing PK may develop post-operative astigmatism of more than 5 diopters. And even after DALC, we do get astigmatism. Now, it can be irregular, and many times it's difficult to correct it with the optical methods. So there are various factors that can cause astigmatism. One, of course, is preoperative factors, then intraoperative and postoperative factors. As far as preoperative factors is concerned, donor-related factor is again an important issue. Infant donor corneas, they induce greater astigmatism. If there is some peripheral change in the donor tissue, some scar or some thinning, then it can have higher astigmatism, and sometimes maybe an early, subclinical or an early keratoconic donor can give rise to astigmatism. If the patient has a condition like keratoconus, then these ectasia cases, they have a tendency to have higher astigmatism in the post-op period. If the periphery at the graft host junction, if there is any thinning, any melting, or any inflammation, any vascularization, all these things can result in higher astigmatism because there is differential tension at the graft host junction, and that is the reason why it results in astigmatism. If you are doing a PK in aphakia, when you have done a vitrectomy and you have not put a Fleringa ring, or even if you have put a Fleringa ring, sometimes you can have a high astigmatism. And for the same reason, if there's a decreased scleral rigidity, you can have high astigmatism. While doing trephination, if the sharpness of the trephine is not good, it is being reused, and it causes ragged edges, then it can result in astigmatism because of the healing process. With time, it results in irregular astigmatism. Graft host disparity again is a factor wherein we have to understand that if we're doing a PK and in the standard, say, healed keratitis or any other condition when we are doing a PK, if graft host disparity, we usually keep 0.5 or sometimes 0.75 if we are doing a triple procedure wherein there's an adherent leucoma, we want to have a deeper anterior chamber. But if the graft host disparity is lesser or if it's too high, then again, there can be astigmatism. And of course, if the donor or the graft is not well centered, it's eccentric, or if the overall graft size is small, if it's less than, say, 7, it's 6.5, the astigmatism will be very high. If the trephination is tilted, this is not a correct method. If it's a tilted donor tissue trephination, then in that case also there's a risk of astigmatism. And of course, as we all know, that if we can have a nice central trephination with a, say, Hesber trephine, and even the donor lenticule can be punched with a good donor punch, and then in that case, wherein you have these holes for suction and these four metal rods for stabilizing it, the donor lenticule, then in that case you can have a central punching, and that's how you can have you can avoid eccentric punching, and then you can reduce the chance of astigmatism. Femtosecond laser again helps you to have a centered cut, as well as you can have have different shapes so as to reduce the astigmatism. There are some other intraoperative factors, but the most important factor is sutures, because these sutures, there are so many sutures, at least 16 sutures if you're doing a graft, whether it's a DALC or a PK. And if there is any differential tension in the sutures, that results in high astigmatism. Then a couple of studies have shown that the interrupted sutures have higher astigmatism in comparison to running sutures. But interrupted sutures have the advantage of selective suture removal also, as early as close to about 10 to 12 weeks. So there you can monitor. And this is one study which was done at our center, and we compared the different patterns of single continuous suturing techniques, and we found out that the TOC technique had higher initial astigmatism. However, after some time, after suture adjustment, the astigmatism was comparable. There are some post-operative factors like how there's wound healing. Like sometimes you have vascularization of the graft-host junction in one area, that area will heal faster, the other area will heal slowly. So there will be a differential tension in the graft-host junction. If you have put non-radial sutures, that will cause a torsional kind of an effect, and that will have a high astigmatism. If there is wound dehiscence, if there's inflammation, all these things can result in high postoperative astigmatism. And as far as preventive measures are concerned, as I said earlier, trepanation should be as central as possible, include all the thinned out areas, use Fleringa ring, definitely in all the aphakic hypotenuse eyes, in almost all the cases, I would say. And host and donor thickness should match at the edge and also in bites. If at the edge, the host and donor thickness are not matching, then there will be improper healing, and that will result in astigmatism. If you are taking irregular thickness of bites or unequal thickness of bites in the donor and in the recipient, then in that case, again, there will be high chance of astigmatism. And as I said, non-radial sutures will cause a sort of a torsional kind of a effect, and that will, after healing, after scarring at the graft-host junction, it will cause an irregular astigmatism. And bites should be equidistant in relation to both host and donor tissue. The idea is that the tissue distribution should be equal on both sides of each suture. So that is what we have to take care. And of course, when we have an astigmatism, then we have to handle it. And we have to see what is the cause of, what was the indication of keratoplasty. And what is the important factor is time after surgery. When do you want to handle it? Like if there is very high astigmatism in the immediate post-op period, it's better not to wait and do a suture replacement. Just see if one or two sutures are very tight, remove it. The moment you will cut it, you will see the release of tension. And then, of course, you replace it with a reasonable tightness of suture, and that will take care of it. If it's not very high, you can monitor the patient and do a topography at 3 months' time. And then you can plan for selective suture removal in interrupted sutures. And if it's a running suture, you have to do suture adjustment. Like if you have an interrupted suture, and if this is the steep axis, you can remove the suture here, and that will take care of it. If you have a continuous suture, you can do a rotation of the suture, loosen the area where it is very tight, and tighten, pull it at the area where it is loose, and then again tie it and bury the knot. If the suture removal has been done completely, and then after that you are having a high astigmatism, then the best thing is to do an optical correction. If the astigmatism is low, then you can manage with spectacles. But if it's high, then I personally feel that RGP contact lens is a very good, safe, and effective method of handling it. As I said, with glasses, you can manage a regular astigmatism, small amount of astigmatism, but high astigmatism, the best thing is mini-scleral contact lens, or if it's not available, you can use a large diameter corneal lens. The Rose K IC design is the best. For these, post-graft Rose K design has been meant for keratoplasty. But the only problem is this, that in most of the grafts, what happens that it is not regularly steep in all the areas. Some area you will have slightly more steepness, in some area it will have slightly less steepness at the graft-host junction. And then this grows.
Doctor, 1 minute left.
Sorry?
No, he's just saying you have a minute left, that's all. Yeah.
Please go ahead.
Okay.
You go ahead.
Yeah. So, if we are giving a large, if it's a corneal lens, it has to be a large diameter diameter lens, and it should be fitted after complete suture removal. As I said, mini-scleral contact lens is the best. And as far as surgical correction is concerned, if the optical methods fail or are not acceptable, then we can do surgical corrections. Like we can do a relaxing incision in the steep axis, and we can combine it with compression suture at the flat axis, so that both work if the astigmatism is very high. And if the astigmatism is high, but significant, but it is symmetrical, it is orthogonal. In that case, we can manage with toric phakic IOL or a toric IOL after doing refractive lens exchange or a laser refractive surgery. LASIK has been found to be effective after keratoplasty. The basic idea is not to do full correction if the refractive error is very high, but to reduce the correction, reduce the refractive error to such an extent that one can manage with spectacles and or a contact lens. Flap creation followed by laser is something that we have followed over the time, a couple of publications from our center, wherein you just create the flap, including the graft close junction, that reduces the astigmatism because it reduces the irregular contractile force at the graft close junction. So in this study, it showed 2.3 diopter reduction of astigmatism at three months. And then, of course, you can lift up the flap after 3 months and do excimer laser. PRK again has been found to be quite effective. Intrastromal ring segments have been shown to be effective. The Kera rings, which are placed at 5 millimeter, have shown in studies to be effective. I haven't used wedge resection. Again, is a tool that can be used to correct very high astigmatism. And if the astigmatism is very high and it is not correctable by anything, there are reports of repeat penetrating keratoplasty as well as repeat DALC if the astigmatism is very high. So in conclusion, astigmatism is a very common problem after PK or DALC. It can have a severe, deteriorating effect as far as visual acuity is concerned. Management can be performed at the corneal level or even at the lenticular level. What I have felt is that miniscleral contact lens, once the suture removal has been complete and still the astigmatism is high and the patient cannot manage with spectacles, miniscleral contact lens has been found to be quite safe and effective and a sort of a reasonable tool to provide good visual outcomes. So thank you very much for your patient listening, and I'll request the panelists to add a few points I might have missed during my presentation.
I thought we should ask this question to Dr. Sudhir. Dr. Sudhir, are you there?
Yes, ma'am.
Yeah, when we are talking about removing sutures in tackling astigmatism, when do you decide that you're going to stop removing the sutures, or the dictum is to remove all sutures?
Removing sutures, actually, in some of our cases, we have left the sutures forever, unless until the patient has a problem. Because if there is no astigmatism and patient is so comfortable, we have some cases where we have never even removed the sutures. Suture removal, generally, we plan after 1 year for a PK, and for a DALC, we try and do it between 6 and 9 months. That is our way. But some of the cases where there is no astigmatism, even not removing the sutures is still very good. Only if there is any loose sutures, then we tend to go ahead and remove the sutures.
And when it comes to doing a phakic IOL or a topo-guided PRK, how long would you wait? When would you do it?
I have not done topo-guided PRK in our cases, but generally I think it has to be a stable astigmatism even after removing the sutures. Then only we need to at least wait for 3 to 6 months. When there is no change, then only we need to plan any of these procedures. If it is going to be a changing, then we should not attempt any of these procedures.
Rajesh sir, I mean, extensive talk, almost really, I think you covered everything possible. The one question regarding the, contact lenses obviously would be the best thing to correct anisometropia, high powers, irregularity, everything it can correct. The only problem occasionally we face is some of these eyes might be patients, let's say of keratoconus, who earlier didn't want to wear contact lenses and then have chosen a graft. And post-graft, very often, it's in these keratoconic eyes that we tend to have a higher degree of astigmatism than the other typical optical grafts. So what is it that you offer first to those patients? I mean, how do you go about, do you look at a lenticular option first, or would you still recommend contact lenses as the first option?
Well,
after suture removal, of course.
For all these cases, my first option will be contact lens, and miniscale contact lens is something which is I mean, earlier it was difficult to fit the corneal contact lens because of edge lift and causing some problems, the rocking movement of the contact lens. But mini-scale contact lens is something wherein the landing zone is at the limbus or even beyond limbus. These are very good lenses, and the patients mostly who were not very happy with corneal lenses are happy with mini-scale lenses. So definitely, there's no doubt that this is the best option. But if the patient is not at all willing for it, then in that case, we would like to see how much is the refractive error. And then in that case, we can give him the options like, one can go ahead with, if the astigmatism is very high, then in such a case, we won't mind doing a relaxing incision, combining with compression sutures. If the astigmatism is reasonable with a high myopic error, in that case, I may go for a toric contact lens. If the, as Dr. Sudhir was mentioning, that toric ICL, as Dr. Sudhir was mentioning, that once the astigmatism is stable, all these things are the option. You can go ahead with a topo-guided PRK, again, not to correct the full refractive error. Even LASIK, which is done, it is not, many times you don't correct the full refractive error, but you want that the refractive error should become such that the patient can be, can be happy with spectacles. Sometimes you are in a position to correct the refractive error fully when the refractive error is not very high, or the astigmatism is not very high. I'm a little hesitant in using intrastomal rings in these cases, because obviously you are putting it at a 5 mm position. Kera ring only can be put. Intacts cannot be put. I have been doing intacts mostly. As far as putting a ring at 4 mm, 5 mm, I'm a bit hesitant in that. Creating a flap only and waiting to see how much is the astigmatic correction also has helped us. So I have done it in a few cases. Although the predictability is not that great, but the average reduction in astigmatism was found to be 2.3, 2.5 diopters. So just do a flap and leave it like that. And after 3 months, do a refraction again and see how much is the refractive error and how much you have to correct. So you have to judge. Full correction and a best correction can, I personally feel, is that the best thing is a mini-scale lens. But these do have all these other methods do have some degree of compromises. Like even the compression sutures and the relaxing incision, the wedge resection, all these are not that predictable. That's the issue.
Dr. Reddy, you have anything to add? You have to unmute.
Unmute.
Yeah, among all, you have explained so nicely about all the factors. The sharpest is refined. So if you can find one donor and one use it, good quality, that I found is very good because we are trying to reuse, especially the punches. When you're punching Katina, we use 2 or 3 times. The first time you get very nice, second, third, it becomes a little bit. And third time, fourth time, fifth time, it becomes very irregular, the donor area. So that's another cost factor. If you can use new ones, I found the astigmatism a bit controllable than
Yeah.
Just a quick question before we close. I mean, to move on to the next topic. I mean, Vanati Madam, Sudhir sir, or Rajesh sir. So very often it's easier to tackle with the steeper grafts, but it is the flatter grafts which make it a little more challenging. Even contact lens fitting becomes a little more difficult in these flatter grafts. So what would you do to address these flatter grafts? Of course, prevention would be the best option, but is there anything, if we are land up with a situation where we have taken a lesser discrepancy and a tighter sutures and the graft is looking a little flat, how would we go about approaching it?
Yeah. So for flatter grafts, as you said, that obviously prevention is the best thing, and mostly it happens if we have taken same size graft in keratoconus and put very tight sutures, and that's the thing. So if you remove the suture completely, once again, see, in these cases, I guess contact lens again is a good option in all these astigmatism. As far as the laser correction is concerned, we have done a study, and there are a couple of other studies which have shown that if the grafts are flat, hyperopic. In that case, the excimer procedure also does not give a predictable result. So that is again, gone. It's also out of question. So once again, in these cases, I would depend more on the contact lens than, if a steeper graft, you have more options. But for a flatter grafts, you don't have too many options. You have contact lens as your savior. This is what I feel. Vanati, anything you would like to say?
I totally agree with you, Rajesh. And flatter grafts are more difficult, more challenging, and prevention is the best way of going around. It's very common when beginner keratoplasty surgeons tend to put more tight suturing, or they make an error in terms of the graft sizing. So this is the most common fact. And if your anterior chamber depth allows, then phakic IOLs is something which you could probably consider in these patients here. Short of that, it's again going to be contact lenses. It's going to be rigid or your scleral lenses, which are probably going to give you the best visual acuity in these cases.
Yes. Anything else? Dr. Rajesh had to leave urgently somewhere. So you have any other question related to the previous talk before we go on to Dr. Namrata's talk? Shreyas?
No, we'll go on.
Okay. So thank you so much, Rajesh, for being there and for that amazing, very detailed talk. Thank you. And do stay on if you can. And we go on to, again, we are breaking the sequence here, but I think we need to really appreciate Dr. Namrata for joining in this webinar, because she's actually running a very high fever. And the fact that she's taking this on actually tells that she's a strong woman. There's nothing which is going to stop her when she has a schedule at hand. And we know what kind of a person she is, not just during her secretary's term, but as a chairman scientific committee, the efficiency with which everything is happening. So we are truly lucky to have you with us, Dr. Namrata. Do get connected, and she is going to be talking to us on IOCT guided DSEC and DMEC. On to you.
Thank you, Chitra, for that kind introduction, and thank you so much for starting this webinar series. I always enjoyed the way you conduct webinars. They are scientifically very rich and absolutely comprehensive and complete, and continue to do so at the platform of Eye Foundation. And thank you again for this opportunity. I would be talking to you about intraoperative OCT guided DMEC and DSEC, and there are no financial or proprietary interests. Intraoperative OCT, of course, is non-invasive and renders an in vivo cross-section view of the optical tissue. And the one which we have experienced is the microscope integrated OCT, which is from Zeiss. Again, no financial interest, but that is what we have in our center. So I think as far as the DSEC is concerned, it helps you to prepare your tissue as well, because you can measure the donor cornea on the intraop OCT microscope and say, with the help of the scale which is there adjacent to this picture. So the tissue is cut using a 400 microns microkeratome, and then after you cut it, you can subsequently again measure this DSEC lenticule which has been cut. So once you measure it with the help of the scale, you know that there is 70 microns residual thickness, and that has been cut. And that this also helps you to plan the microkeratome which you are going to use. So for instance, if you have because you know that microkeratome will cut, especially the microkeratome which is given by Moria, will cut 50 to 60 microns more than what you would desire, and the Gabor one would cut 50 to 60 microns less than what you desire, so that you can take that factor into consideration and you can titrate without having a perforation and without having a very thick graft. Now, this is what we published, the IOCT guided donor dissection for DSEC, and how you do it is given in this article in Indian Journal of Ophthalmology. Of course, evaluation of time to donor lenticule apposition using IOCT in DSEC can also be titrated, and this is very nicely and in a very elegant manner described in this paper, where it clearly says that if it is opposed within 1 to 3 minutes with a technique for simultaneous positive intracameral pressure and external corneal massage, then your job is done. And in 3 minutes time, the graft actually gets opposed and you can do the external massage as well. So this is just to show the same where the graft is pulled intracamerally. Even if your media is hazy, you can actually see that it is where the graft is, because the intraopacity allows you to see so. And then you know whether it is lying on the iris or it is midway, as it is midway in this case. And then you can inject the air bubble so that the graft gets stuck to the cornea. Now, there are some microscopic areas where it is still not stuck, and as you hydrate the wound, the graft moves. So you know you are not still done. And you have to again hydrate the wound, and again it is moving. So you have to do external massage to release the fluid from in between the interface that is present. Even when you do a ultra thin desec, it allows you to do so, because first you can do a graft which is, ultra thin. And sometimes that ultra thin graft that you insert may go upside down. Just like in this case, this is upside down. But looking at the configuration, you know that it is upside down, and then you have to actually get it into the correct configuration. So this is the correct configuration when it is concave along with the cornea. And if it is convex, you know that it is upside down graft. And again, this again helps you in cases of ultra thin desec, and then you know which side is down, and you have to get endothelial side down. So these are some of the pictures of ultra thin desec done less than 100 microns, where in the diffuse you can't even make out that there is a graft periphery to it, and in the slit you can make out that there's a very thin periphery to it. In cases of shed, it plays a very important role, because in shed you can practically see nothing. These are the descemet membrane remnants, which you can't see, but we've stained it with a trypan blue dye. And once you put that silver reflector inside, you can actually see these, and also can locate them on the intraop OCT microscope. So this is one way of doing desmeto, peeling out the entire desmets. In cases of shed, of course, people have said that even if you don't do it, it's fine. But if you want to do it, like I always want to do it, it is always best to use this. And you can also see it on the IOCT. Now, this is once you instill the graft, it looks, you don't know where it is, but once you place it and you see it on the intraop OCT microscope, you know where it is. Plus, important thing is that these are phakic eyes. So your iris will keep bumping up. So if you look at the intraop OCT microscope, you also know the titration point, which is the end point. And you know that the iris is not touching the back of your desec graft, because it's so hazy, it becomes difficult to see otherwise. This is just to show the desec and how a graft would look like in the post-operative period. Another one in shed to show the graft, how it looks like. And this, of course, we published in shed, the MIOCT guided desec in cases of shed, and all the trips and the tricks thereof. Now, of course, in optical, in pediatric keratoplasty, it also helps. And again, this is what we've published. This also had cohort of lamellar keratoplasty, both anterior and posterior. And these are the results which were published in American Journal of Ophthalmology. Now, when the graft is actually detached, and when you need to rebubble it, again, IOCT does come to your rescue, although you can do these procedures even without IOCT, especially if the cornea is clear. But then it just helps you to titrate your steps better if you have it. And it helps you to know that the graft is absolutely opposed to the recipient, and there are no microscopic or submicroscopic gaps as well. In the DMEC preparation of the graft, I don't think it is of too much help, because one uses trypan blue dye, and that essentially does the trick. So this is the trephination which is being done at 9.5 millimeters, and subsequently the graft is stained with the trypan blue dye, and this is being pulled in one direction, and subsequently the graft is pushed back. This is in fact my very first case of DMEC when I was not using the S-shaped stamp. Okay, that is the other one. So here the S-shaped stamp is being used here, and this lid can then be closed. And the trephination is that done at 7.5 millimeters or 8 millimeters, and then this graft is then placed into the Petri dish. And I like to keep it like this, and I like to load it like this so that it doesn't get loaded upside down and you don't have to struggle with its orientation later on. Now, this in fact was the first DMEC, in fact, that I did, where we did not put a S-shaped stamp, and the desmetorexis is being done in a case of Fuchs dystrophy with cataract. So cataract surgery has already been done, and the desmets is removed. And again, you can look at the remnants if there are any which remain. And this is then intracamerally injected. And this is upside down. So you have to flip it because you have to get the biceps curl upwards. So you inject the fluid so that now it is flipped completely. It is upside down, and then tap, get the AC to shallow, and then inject the air bubble. Now, this one didn't have a S-shaped stamp, but IOCT came to the rescue. But of course, this was the first case. So subsequently, we've started doing both the IOCT as well as the stamp, both. So this was the case which was there on the first week 1, and this was subsequently where you can't make out very thin. If you look at, you can make out that there is a DMEC graft there, which is only 20 microns. This was a DMEC in hazy cornea, and I think in hazy media, it really helps a lot to have intraopacity microscope, because sometimes even the S cannot be seen. And the Descemet's membrane is also not piecemeal. So you have to look at the remnants. The graft is then inserted and subsequently get it into the correct orientation, which is the biceps curl upwards. Now, I can't see the S-shaped stamp here at all, but IOCT again helps you to identify the correct orientation of the graft. The air bubble is instilled, and subsequently, I think there is a faint S, which is over here, which can be seen. So this is in the post-operative period. Over a period of time, it clears up. Now, sometimes you can have folds in the DMEC graft, such as in this. So you tap, the media is quite clear, and the S is also there. And then when you tap, this fold remains. Of course, you can leave this fold also as such, but the best way of addressing this fold is that with the help of the fluid and the cannula, you inject some fluid and subsequently inject air. So when you inject the fluid between the graft and the host, it will kind of unfurl. And when you inject air simultaneously, the fold will be taken care of. Then this is yet another case where the folds in the graft were present, and this is a double scroll kind of a thing, which is folded on itself, and then you tap, it becomes difficult to make out again because it is hazy. But then by looking at the intraop-OCT microscope, you can again get it to the correct orientation as is seen in this case. This is DMEC in eye syndrome. Again, it helps there because there are remnants which are there behind the cornea, and these can again be addressed. And of course, following the same technique, injecting the graft, one can inject the air bubble, and then subsequently the graft gets attached. And this is the post-op picture of the same. Of course, we published this in IOCT in anterior segment surgery. And then to conclude, I would just like to say that for corneal surgeons, whether it is anterior or posterior or keratoplasty or ocular surface disorders, I think the intraop OCT is a boon, and it helps to see the third dimension. It acts like a third eye, enhances your visualization. It helps to refine your surgeries better. I'm not saying it is prerequisite, but I'm saying that it is here to stay, and I think it is the future. And I know that most of us are still using it. Although modifications and quantifications may be required for this because technically it is a little challenging. You need somebody to keep monitoring and keep changing the focus where you are working. But it is quite gratifying, and it helps you a lot during the surgery. Thank you so much for your kind attention. Chitra is muted.
Yeah, that was a wonderful talk, Namrata. Although I'm not a cornea surgeon, but it was so amazing. It actually left me wondering that the surgery done without IOCT, I mean, that is a huge challenge. And Does that change any management protocol because you don't have an IOCT besides the visualization issues? I don't know, but it was
We
a
have
good
great
talk.
corneal surgeons here who do most of the corneal surgeons, in fact, do without IOCT. So I'm sure, I mean, we are learning from them only, and it is only that IOCT is helping us to, doing those steps better. That is all. But I'm sure everybody and anybody can manage without it.
On to you, Shreyas.
As always, madam, I mean, wonderful set of videos and slides, and always a real pleasure listening to you and learning from you. I know the topic was on IOCT in DSEC and DMEC, but you'll use it more with the posterior lamella, or is it also useful in antilamellar DALK? Do you really are able to see how deep you've gone before injecting big bubble, for instance, or if you're doing a manual dissection, how much is left behind and where, how much deeper? Does it help with anterior lamellar also?
It helps a lot with the anterior lamellar also. I think it helps more with the anterior lamellar than posterior lamellar. When you inject the needle, you know at what level you are. So when you know you're at 80% or 70% depth, you can inject the air bubble. Then sometimes when the air bubble actually is going in between the desmids and duas, you can actually see it. You can visualize it on the intraopposite microscope. Or if even when you are dissecting, again at what level you are. If you have a small bubble, you can actually visualize on the IOCT and you can enlarge that bubble. So I think it helps a lot in your anterior, in your DALKs. If you have a desmetocele, then again it helps you a lot. So that is another story how it helps, but I think it helps everywhere. Ocular surface disorders, your pannus excision, your chemical injuries, how much is the pannus, whether you have to do your lamellar keratoplasty or not. If there's a perforation, again, how much to seal, where to seal. So I think it is a great tool to have. But I think the Indian company should come up with the indigenous tools. And I think Appaswamy is already coming up with that so that it is available to all. Now, this is something, it's like your diagnostics getting married to your, operating. So now we have a OCT, then I'm sure one day we'll have a pentachem where, or we'll have a astigmatic tool which can, immediately help you to obviate the problems of astigmatism which occur after keratoplasty. So your diagnostics are entering OR, which is a good thing.
True. Very true.
Wonderful, madam. Any other points, Vanati, madam? I mean, rest of us don't really have access to this device, so maybe I'm not sure if Sudhir sir also has access to it.
I think the greatest advantage of having an IOCT imaging during intraoperative is when you're training residents. I think that's where it really scores over. It really helps you to monitor, and it helps you to be of good assistance in the event they are having any problems. Apart from that, when you're doing difficult scenarios, like when your graft has become upside down here, you're really not able to make out, you're having a long duration of surgery, your marking has disappeared. Those are scenarios. And of course, in pediatric cases, again, because your chamber is shallow. And again, where the amount of opacity and your preoperative evaluations are all compromised because you always need an examination and anesthesia. So that's where it really helps you to look at how the iris lens configurations are attached when you're looking at congenital corneal opacities, and if you're doing an endothelial procedure in pediatric eyes. So these are special scenarios where it really scores over not having an IOCT here. But that said and done, we all trained in an era when these did not really exist. So it's like, driving any functional car over driving a Porsche or, a Tesla. It is, the more the luxury, the better your outcomes are, and the lesser complications you're going to have in the postoperative phase.
That's very true.
Yeah.
Thank you so much, Namrata. Get well soonest. I hope tomorrow itself your fever disappears. Thanks a lot. Do stay there. You can always add something extra for the remaining talks, and get well soon.
Shreyas, we use bioptician.
Okay,
It is, yeah, but it is not that as good as
COVID,
but it is good enough for some of the cases like DALK to know how much is the if you're doing a manual DAC, how much is the thickness left over in those scenarios, but it's a little cumbersome to use it. Yeah, otherwise it will serve, it serves purpose.
You have to shift the microscope away and bring the biogenetic.
Correct.
Thank you. We shall now go on to our, it's okay, Shreyas, we can go on to the next one. We have Dr. Shrish Kumar, who's our medical superintendent, our senior consultant, an amazing cataract, cornea, and refractive surgeon, a gem at our hospital. And he's going to be telling us about complicated situations in DALC and its management.
You're on mute, sir.
Thank you, Dr. Chitra. Thank you, Dr. Shreyas. So my topic is complicated situations in DALC and its management. So complicated situations in DALC can be a pre-existent condition or it can happen intraoperatively or post-operatively. And coming to the procedure of DALC per se, it is well known that now when air is injected into the corneal stroma, three types of big bubbles can be achieved. Type 1 big bubble, which is a white margin bubble. Type 2 big bubble, which is a clear margin bubble. And type 3 bubble, which is a mixture of type 1 and type 2. And type 1 bubble is the commonest type of big bubble which we achieve in most of the cases, almost 80-85% of the cases. Here the cleavage plane is between the stroma and the pre-descemetic layer or Duas layer. And type 2 is here it's the clear margin bubble, and the cleavage plane is between Duas layer and Lesser layer. And it is a large bubble. It can even reach up to 10.5 millimeters, and the chances of perforation with this kind of bubble is high. And one should be careful and modify their surgical technique accordingly. And coming to the third type is a mixed bubble or type 3 bubble. Here it's a mixture of type 1 and type 2 bubble. Either you have a large type 1 and a small type 2, or you have a large type 2 and a small type 1 bubble. Again, one should be very careful because chances of rupture is very high. So the difference between type 1 and type 2 big bubbles, if you see the surface here, the anterior surface of Duas layer, after creation of a type 1 big bubble, the broken strands, it is not very smooth as it is on the right hand side. So this suggests there are few strands, broken strands or fibers of collagen that gives a rough looking appearance. And this is because of the type 1 bubble, the separation is between Duas and the posterior stromal layer. And here, the anterior surface of the descemetic membrane is exposed after creation of type 2 bubble, and the surface is very smooth and featureless with no visible fiber. One should be very careful handling this situation. And keratoconus is one of the common indications for DALC, hence a detailed preoperative assessment of keratoconus by means of anti-segment OCT and its staging according to Sandali classification may provide useful information for the surgical management and planning of DALC in terms of both the timing of surgery as well as the technique employed. And surgical intervention before stage 3A, before the development of posterior stromal scar, you invariably get a type 1 bubble, and you can safely go ahead with the window technique. And beyond that, 3B onwards up to 5B stage, you can have posterior stromal scars or panstromal scars. One should be very careful. You may get a type 2 or a type 3 bubble, or if it is a panstromal scar, you should do a manual dissection directly. This is the algorithm for performing DALC, taking advantage of preoperative OCT. So clearly like up to 3A, stage 3A, where there is no posterior scar, so we can safely go ahead with the big bubble technique. And beyond that, 3B, 4, and 5A, 5B stage, we can go ahead and do a manual dark. So you can even use IOCT and check whether you can safely go ahead with the surgical procedure. So this is one case example. Particular patient is an advanced case of Keratoplasty, and there is a scar, but it is a superficial stromal scar, and here invariably you end up with the type 1 big bubble. What showing here, that is the type 1 big bubble. I usually do a superficial keratectomy to debulk the cornea, and then with the 11 number weight, make a neck incision and inject visco into the neck incision to prevent the forward movement of the desmites, to keep desmites away from all the manipulation. And with a blunt tipped one scissors, I divide the posterior segment into 4 quadrants or more than 4 segments, and it is completely excised using the Vanna scissors. And now the donor's preparation. Once this is done, I wash off the surface with the and place the graft on the host bed, and insert it with the monofilament nylon. This is another case of advanced keratoconus. If you see here the OCT picture, the scar is extending to the posterior stroma, and of course it has not reached the desmites, so it is extending to the posterior stroma. And these are the cases you have to be very careful, and the chances of type 1 big bubble is rare. You invariably end up with a type 2 bubble. If you concentrate here, you can see a nice type 2 bubble forming. Yeah, it is a clear margin, large bubble. So you have to identify this, and then you modify your surgical technique. And here I am going ahead with the manual dissection, and you can reach up to pre-desmate level. There are multiple small bubbles that will give a rough. They act as a rough guide. You can stay above those multiple bubbles and complete your procedure. So this is another case of advanced keratoconus. Of course, the healed hydrops, and there is a scar which is paracentral, and this is the OCT picture. There is a panstromal scar here, and so this is the case wherein you should plan your surgery. You should go ahead and do a manual dart. I'm injecting air bubble just to create an emphysema. This is superficially I'm injecting. It is not to accomplish any big bubble here. And this helps in the dissection. You do a layer by layer dissection and reach pre-desmatic level, and place your donor and suture it. This is the postoperative picture of the same patient. The first postoperative picture. This is 6 weeks, and this is 1 year picture. So you can see there is a small scar here. But it is not in the center, it is paracentral, and the BPA is almost normal. The patient had 6 parts with a small cylinder. And this is the preoperative OCT, and this is the postoperative OCT of the same patient. And the complications, various complications, the commonest complications we encounter is the perforation. It can happen at any stage. It can happen during the refination itself, or while injecting the air bubble into the anterior chamber, into the cornea. You end up injecting into the anterior chamber. So it can happen even at the end while suturing. It can happen. So these are some of the other complications. I'm not going into the details of these complications. And we recorded and evaluated the intraoperative and postoperative complications related to DALK and published it in IJO, which was published in 2022. And subsequently, later we published our complications of DALK in a large series of close to 480 eyes in OJO last year. So this is a case where I'm performing DALK. There is a small perforation which has happened here. Yeah, it started leaking the air bubble, and you move away from the place of perforation. You dissect in the other areas and inject the air bubble and try to maintain the anterior chamber. And that's the end of the surgery. And but to our surprise, the patient had a large detachment, and there is a small bubble and some fluid also was there in the interface, and went ahead and aspirated the fluid and air from the interface and injected a air bubble into the anterior chamber to tamponade. And always see to it that it is a mobile bubble, and it's not causing any pupillary block. This is the preoperative picture, and this is postoperative, and this is how it was at the end of 1 year. There was a perforation, a small perforation, but it has healed very well. This is another case, advanced keratoconus, which is healed hydrops, and this is a very old video. The clarity is not very good, and I'm doing a manual dissection here. Ended up with a perforation, which is paracentral perforation. You can see the perforation, but most of the dissection is complete. But I continued with the DALK. And to my surprise, this patient did very well. You see the postoperative picture. This is a 6 month picture, and this is 1 year picture. The area has healed so well, and it is away from the pupillary area, and the patient has improved to 6 pass. And the scarred margins, a long-standing healed hydrops, usually these tears will not enlarge because of the scarring of the margins. So you can always go ahead and do a DALK, attempt a DALK in these cases. You go ahead with the manual DALK if the scar is paracentral. And outcome of deep anterior lamellar keratoplasty patients with intraoperative Descemet's membrane perforation. We did a retrospective analysis, and fortunately, the postoperative prognosis when these perforations are successfully managed, it does not deviate from the expected prognosis in uncomplicated cases, because most of the time the DALK procedure can proceed as planned. Hence, the rate of intraoperative conversion to penetrating keratoplasty after small TM perforations has significantly dropped. In our case also, it was very less, like the percentage of conversions is very less. Out of 480 cases, 7 cases of perforations we converted. We had 21 perforations, but only 7 needed conversion to PK. This is a case, very old video of mine, almost 15 years old video, and I have reached Dua player. This is a Dua player which I should not have done, and I'm using a sharp instrument also. Very enthusiastic about it, and I even showed this video to Dr. Dua in a Karkon meeting. He also appreciated it, but I didn't show the later part of the video. It's only up to this I have shown. But I continued my dissection. This is what happened. It perforated. There was a limbus to limbus tear. So a large tear. So I had to convert this into PK. The patient ended up with the PK. But of course, the patient did very well. The visual acuity. This is the case of macular dystrophy, and his visual acuity had improved significantly. Another complication which I have encountered was rare complication, interface infectious keratitis following adult, and it needs graft lift and interface wash. And due to the dislocation and the rapid spread of the infection and poor penetration and efficacy of these topical medications, we have to intervene in these cases. And so this particular patient also did well. We did the graft lift and gave interface wash. And this was published in 2016 IJO. And other rare complications like wrinkling of DM, if the wrinkling happens in the center, it can affect the BCVA, but if it is in the periphery, it may not affect the BCVA. And these are some of the common complications. Raised intraocular pressure could be due to various reasons, and wound dehiscence or cataract formation due to various reasons. And recurrence of the disease is a case of granular dystrophy, and for which I have done a DALK, and patient developed recurrence of the disease. Of course, it has not affected his BCVA, so we continued with this. And rejection, which rarely can happen. You can see the vascularization here. Because of the vascularization, there was a suture here. I removed it, and instead of this, there is a localized stromal edema, and this responded to topical steroids, and the patient did well, and it didn't recur. So, to conclude, DALK procedure should be considered prior to PK, as it helps preserving the healthy endothelium, and it eliminates the risk of endothelial rejection. And it's safe and very effective in indicated cases. And I believe that wherever it is possible, DALK should be performed as the standard of care surgery when keratoplasty is indicated. Thank you very much.
Thanks, Shrish. That was a wonderful talk. Very descriptive and informative. Very good. So one question, Dr. Sudhir, if there is supposing a localized ectasia after a suture removal, would you reapply suture then and there?
Yeah, yes, ma'am. I think handling suture is very important. Whenever you find there is a loose sutures and there is a gaping, we need to handle this immediately. Otherwise, this will land up with irregular astigmatism. Right?
And if there are interface vessels, how do you reduce or how do you correct that?
We need to find out where these feeder vessels are coming. If you know those feeder vessels, you can cauterize them or use argon laser. And we can also step up steroids. So that also helps. In scenarios, we can also try out anti-VEGFs in subconjunctival anti-VEGF. So that would work. But stepping up steroids would most commonly work along with cauterization of these feeder vessels.
Yes.
Can I come in? I had two cases of interface vascularization, and in one case, I could see a loose suture, and the other case, there was no such suture, loose sutures, or it was a case of macular dystrophy. I don't know from where the vessels was growing into the interface. So that patient, I put him on steroids for some time, and then continued with cyclosporine eye drops. And those vessels regressed, and the patient is doing well.
On to you, Shreyas.
One question which I had, sir, was that, sometimes, especially in these very advanced keratoconus, we have a lot of redundant decimus membrane, which leads to a lot of folds. And on and off, we get these fixed folds in the center. Any tips on how we can avoid them? What we can do to, while suturing, any additional technique that we would follow?
Usually, if it is a very, very advanced cone, so we should take a slightly larger graft. If it is a same sized graft, you end up having fixed folds. And if these folds are in the center, it can lead to a drop in BCVA. You slightly oversize the graft by 0.25 or 0.5 millimeters also. And of course, you end up having a myopia, but it can be corrected.
Anything else to be discussed? Dr. JK, Dr. Vanathy, you want to add any point on this before we go on to our best for the last?
No, all
Nothing.
covered comprehensively. I think we can move on.
So we start off with introducing our very dear Dr. Praveen Krishna, who is the network director and also is the director of the Corneal Institute of Excellence of LV Prasad. And as I said, I meant it from the depth of my heart, best for the last. But I shouldn't say it too often because the other speakers were too good too. So he's going to be talking to us on DMAC in challenging situations. On to you, Dr. Praveen. It was really not in our agenda to keep you as the last speaker, but I think keeping you as the last would have all those people waiting for your talk.
1 minute, Dr. Rajesh talk is there, no?
Yeah, he had some guests and pre-booked a table and the country.
Yeah, cool. I think going last, the biggest advantage is nobody is going to cut you off in the middle and say that 1 minute left. So I hope I have a little more time going at the end. So there are some advantages. So thanks a lot, Chitra. Thank you, Shreyas and Chitra and everyone else for putting together this very nice meeting. So the topic that I'm going to be speaking about today, and I did enjoy some of the earlier talks, and I think they also had. Okay. Can you see my slides all right now?
Yeah, we can. Yeah.
Fantastic. I think they also had some very good clinical points as well. So what I'm going to do in my talk, which is supposed to be about special situations in DMAC surgery, is I was thinking for the last few days on how to put together a talk for 10 minutes about special situations. And then I was scratching my head. And then I decided that it's not possible to do that because special situations in DMAC by themselves, each of them probably is like a 45-minute or a 1 hour kind of a workshop, probably even longer. So what I thought is I'll just give you a flavor of each of these challenging situations with one take-home point each, so that if there is a requirement for a longer discussion or maybe a future talk about any of these areas, we could probably dive deeper into them. So what I'll do is I'll talk about primarily 5 challenging situations, if time permits, maybe a 6th. First is about poor visibility during DMAC surgery. Second is dealing with irregular surfaces during DMAC surgery, especially the posterior surface. Then about unstable IOLs, then about shallow chambers, deep chambers, and then interface fluid, along with endothelial dysfunction as well. We'll try and just give a case examples of each of these and try and see what is it that we can learn. The first situation is poor visibility. Again, there are a number of scenarios that you can have poor visibility in. But the reason why I chose this is the fact that this is a failed DSEC. And the reason why I chose this is because this is probably one of the ideal cases for DMAC surgeons who are at the beginning of their learning curve to pick these cases for their first few DMAC surgeries. The reason is these are patients who have relatively poor vision. And once you strip the DSEC graft off, the visibility actually improves very, very significantly. So you have a patient who has probably slightly lower expectations, but you also have a cornea that has relatively good visibility once you take the epithelium and the DSEC graft off. Here is an example of a video that I'm actually going to show what happens when you take off the DSEC graft and the epithelium. Are you able to see my video? Is it moving?
Yes, it's moving.
Fantastic. So once you take the epithelium off, the visibility does improve. And then once you take the DSEC graft off, in fact, the visibility improves to almost have a clear cornea. So these are the ideal kind of cases that you would like to try DMAC in. And here you go, that's the DSEC graft coming off. And you will see that the added advantage in this case is the fact that the iris is also light colored. And so the blue DMAC graft against the light colored iris also stands out really well. So this is the ideal kind of situation to have when you're doing DMAC in your early cases. So I'll just let this run for a few seconds. Here you see actually that I've also marked the DMAC graft, which is another thing that you should do as surgeons who are beginning. All of us don't have an IOCT, so the mark actually helps a lot in confirming what is the correct orientation. And if you know that the lenticule or your DMAC graft is in reverse orientation, then you can spend some time trying to ensure that it's in the right orientation. And most of the time, once you understand the fluid dynamics and also know how the graft will move inside the eye, after that, handling it and opening it is no great shakes. It actually is relatively easy to understand how to manipulate the graft. So this is post-op day 3 of the same patient, and you'll see that the cornea is already quite compact and quite clear compared to how it is looking preoperatively. Same patient 2 months later, and his best corrected visual acuity is 20/30. And you saw the difference that a DMAC makes in a cornea that is not clear. The other very important, I think, tip in patients where you have relatively poor visibility or you're not able to make out what's going on, in addition to making a mark, I make a P mark as you see here, is to have what I call the poor man's IOCT, which is the light pipe during surgery. Because once you make a mark, and sometimes if you have a very dark brown iris like you have down here, you might not be able to make out the mark that you printed on the cornea. Instead, if you use a light pipe, you'll be able to see the mark much better. Here you can see it like a 9, and that will help you to also manipulate your graft in the correct orientation. And once you get it in the correct orientation, then once you stick it, then it's much easier to see. So the light pipe it doesn't cost a lot of money, about $1.5 lakh to get a light pipe system along with the light pipe, and it's very, very useful to identify orientation in DMAC. Second scenario is irregular surfaces. Again, this is something that I probably learned the hard way. If you have a post-PK patient where you have poor visibility in the graft host junction and you're doing a DMAC, this is a post-DSEC eye. So I'm taking off the old DSEC graft, hoping the visibility will improve, and I'm trying to do a DMAC. This patient also has a tube, so he has multiple comorbidities. You see that there's a tube here, and he also has Seneca. So I'm trimming the tube before I put my DMAC graft inside. So at the end of this, I'll also give you another tip that I think I follow nowadays. So the surgery went off relatively, easy in the beginning. But once I started trying to manipulate the graft and try to inject an air bubble, in fact, I had some bleeding, and I was able to handle that as well. But the tip here is the fact that if you have a very dense graft host junction, what is very important for you to do before surgery is to do an OCT, because as you can see in this picture, there is edema on the side of the graft. And when I do an OCT, I'll see that there is a very prominent graft host junction, which is not going to allow your DMAC graft to attach whatever manipulation you do inside the eye. So if you have a very irregular and a prominent graft host junction on the posterior surface, you should be able to predict this with an OCT. And in fact, cases like this, probably the ideal surgery to do, going back to what Dr. Revati said, is probably to do a PK. Because even if you do a DSEC or a DMAC, DMAC is very tough because you'll have to use a very small graft. DSEC as well, you'll be implanting very few endothelial cells. So it might be a good idea to do a PK instead of a DMAC or a DSEC. Now, coming to the third scenario, which is shallow chambers or ice syndrome. Here is an example of a patient, youngish patient with Chandler syndrome, extensive PAS, as you can see all around. The OCT of the angle, this is the OCT that shows that almost all his angles are closed off. So I'll show a very brief video just to show you the synochialysis and why it is very important to do this step. Because this step is how you convert a shallow chamber into a deeper chamber. So initially, I'm putting an air bubble inside the eye, and you'll see that the air bubble actually breaks up and also doesn't really fill up the entire anterior chamber. It only goes somewhere up to like the mid-periphery, and that is the amount of space that is available inside the anterior chamber. So putting an AC maintainer and then doing a meticulous synochialysis is what is going to create space for you in this patient to be able to do DMAC surgery. And after I do a complete synochialysis, has to be slow because you don't want a lot of bleeding as well, because bleeding is going to lead to fibrin. Fibrin is going to lead to difficult unfolding of your graft. And this is where the AC maintainer is very important because it will continue to remove any blood from the eye and doesn't allow fibrin buildup. Sometimes the Sanique also pulls off the Descemet's membrane. And so it's very important to go in and smoothen the iris. Otherwise, your graft will not have place to move. So this is what I'm doing. I'm trying to shave off the anterior surface of the iris, which has parts of the Descemet's membrane stuck to it before I put my graft inside the eye. And this is really important because if you don't do this, then your graft will get stuck. It's not going to move. It's not going to be able to open around. You can even use a retractor to do this. So this is the DMEC being done, and I won't show you the entire sequence. It is relatively quick. But what I want to show you is the size of the air bubble. And you see this is an air bubble that is placed inside the eye. And you see that you can't see the margin of the air bubble because it's gone completely into the angle because of the Sanique that were released. Same patient, post-op day 7, really clear cornea, almost no Sanique as you can see. Same patient, post-op day 30, doing really well. Fakey guy, young guy, about 27, 28-year-old chap, and very good endothelial cell count as well after DMEC surgery. The same kind of scenario also occurs very commonly after cataract surgery in patients who have TAS. You have a fixed dilated pupil, plenty of Sanique in the periphery, and sometimes CME as well because the inflammation post-op. These patients also the same approach, meticulous saniculitis. You need to be a little careful of the dilated pupil, but you can do DMEC. They do tend to have some amount of posterior stromal scarring, as you can see here, because of inflammation in the posterior stroma, but they usually have relatively good visual recovery. Fourth scenario, deep anterior chambers. Again, this is not something that I would recommend that you do right away. And this is, again, one of those showboating kind of videos that I'm going to show you just to show you what can be done. So this is a case where I have a ACIOL. This is about, I would say, six years ago or so. ACIOL that appeared to be small. So what I did was I did a vitrectomy, did ACIOL exchange. And after that, I put in a contact lens, a prosthetic contact lens to actually serve as a template on which I could unfold my DMEC graft. Now, I probably would just take off this ACIOL and put an iris claw lens, or maybe even ask my retina colleagues to do a glued IOL. I don't do a glued IOL myself. But then this was the time of potential youth in the DMEC world. So that is when we want to do DMEC on everything. And so I thought I'll do something different. And here, what I'm trying to do is trying to fold white prosthetic contact lens into the anterior chamber, insert it and unfold it so that it actually prevents the DMEC graft from going posteriorly, also shallows the anterior chamber, and in addition, gives us a fantastic visibility of the DMEC graft or the blue DMEC graft against the white lens. So I'll forward this and you'll see that this is where the DMEC graft is being injected, and you'll see that visibility is definitely not a problem here. You can see the DMEC graft really well. The AC is relatively shallow, so the graft also behaves itself. It is not touching the IOL, though it might be touching the PCL. And eventually, I will get this to unfold, and I actually get it to attach to the cornea. And once I get it to attach to the cornea and unfold completely, then I can go in and remove the bandage contact lens. So I'm just removing some of the fluid, some of the air with the fluid after the graft is attached for 10 minutes. And then I'll go in and I'll take off the bandage contact lens. You can also cut the bandage contact lens and take it. In this case, you saw that the contact lens was actually touching the graft in one area, which is not very desirable. Same patient, post-op day 7, showing that the patient did really well. And this patient also has about 1.5 years follow-up before I lost follow-up for this patient, but did pretty well, had a decent amount of endothelial cell loss, not unusual from what I would expect, but I thought that was a good technique, except it was too time-consuming. Here is another scenario where you can also do the same kind of surgery in a patient. This is a patient with an ICL who had a corneal decompensation and needed a DMEC surgery. If you remove the ICL to do the DMEC, then you have a very deep anterior chamber. So actually surgery is tough. But if you keep the ICL, then you have a very shallow anterior chamber. So you actually have a dilemma of what you want to do. So I decided that I'm going to keep the ICL and do the DMEC in the shallower chamber, because that's where I would prefer a shallower chamber than a deeper chamber. Again, won't bore you with the surgical details, But then this patient did really well from the point of view of the outcomes. And we were able to do a DMEC graph. This is just the surgery and showing you the DMEC attachment post-op. The last scenario that I would like to share with you is an interesting one where we were faced with patients who came in with interface fluid in a patient who had LASIK surgery. Normally, after LASIK, if you find that the pressure is high, that is when you'll find interface fluid. And also, you expect that once the pressure normalizes, this tends to go away. But then we had a patient who came in with IOP completely normal, but with interface fluid. And then when we saw that there was a massive cleft in between the flap and the stromal bed, OCT revealed the fact that there was a fluid cleft that was lined by epithelium. You can actually see the epithelium in the fluid cleft. And the posterior stroma also had quite some edema. And the Descemet's membrane was also quite thick here too. So this patient was a patient whose other eye revealed that she had Fuchs dystrophy. She had LASIK about 10 years ago. And then after the LASIK surgery was done, she was doing very well. But once she decompensated, then she had this interface fluid. So what was interesting here was that we had to operate in two different planes, right? So we had to first lift up the LASIK flap and evacuate the fluid that was there in the interface. And also the epithelium that was lining that LASIK flap on both sides, that needed to be removed quite meticulously as well. So this is me trying to open up that epithelial cyst. And you will find that it's actually quite fibrosed. And once I enter it, there'll be a gush of fluid. And again, for lack of time, I probably won't show you the entire video. But then this is the more interesting part about how you actually open up the LASIK flap and how you ensure that all the fluid is removed. In fact, the flap was so adherent that in one area, we had to use a crescent knife to slice it open so that it actually has a clean cut rather than just rip it open. And all of this is the epithelium. And the epithelium, we again rubbed it off, and then we used alcohol to ensure that there is no epithelial cells that are left behind. So it is quite a long surgery. In fact, this took longer than the actual DMEC. Once that was done, then the underside of the flap, and then we did the DMEC like you would do in any other normal case. And the DMEC did very well as well. And we used a roller. This is post-op day 3. Interface fluid came down significantly, but there was still some interface fluid. Post-op 9 months, she did really well. Vision recovered to 20/20 with correction, and she's really happy after the surgery at this point of time. Good endothelial cell count as well. So this is post-op and this is pre-op, show you the stark difference. And one last similar scenario that we faced was another patient who came with the same kind of a problem, a LASIK flap, a cataract, uveitis, and also glaucoma. And this was a patient who had one of these infernal cosmetic iris implants in her eye. This is the eye of a sibling. She had her implant removed because of inflammation and glaucoma just before she came here, but her cornea decompensated. But she also had the same kind of interface fluid syndrome. So we were able to eventually operate her, did a DMEC and put the flap and removed all the epithelium in play from the interface. She did pretty well. She developed secondary glaucoma, required a trab, then a tube, and now is just hanging on for dear life with the DMEC still doing pretty well about 2.5, 3 years down the line as well. So just to, that's the OCT. Let's to summarize the challenging situations that we went through today. Poor visibility, ensure that you take off the epithelium and take off any other intervening structures like a DSEC graft that will improve visibility. Use a light pipe to ensure that visibility is better. If you have irregular surfaces like a post-PK, make sure you do an OCT before you take them for patient for surgery. Sometimes doing a PK might be better than DMEC or DSEC. Unstable IOLs are potentially best exchanged because the surgery in DMEC is also going to be shallowing and deepening the chamber quite a lot. If you have a shallow chamber, surgery is still possible, but spend time to ensure that all the synechia are removed so that you create space for yourself. If you have a very deep chamber, potentially now, I would say that very deep chambers, DSEC is better choice than a DMEC surgery, but you can use that prosthetic CL trick that I showed you. When you're in your early part of your learning curve, gung-ho and you have a lot of energy, maybe you do that. but later on you want surgery to be quick, easy, and also uncomplicated, probably I won't do it now. And if you have interface fluid, again, the interface fluid might be because of endothelial dysfunction. So the answer might not just be draining the fluid, but also ensuring that you replace the endothelium. Thank you very much for your kind attention.
Thank you very much. That was an awesome talk, Dr. Praveen. So what I would ask before Shreyash takes on is, can you tell me when you would not do a DMEC? Or rather, with your kind of experience, when would you do a DMEC or when you would do a DSEC?
I think 3 simple rules rather than go through scenarios. I think where making a choice of doing a DMEC is not going to benefit the patient from the vision point of view. Like say somebody has maybe retinal pathology or maybe has poor visual potential, then taking the extra effort to do DMEC probably doesn't make any sense. I think number 2 is where the disorganization in the anterior chamber is so much that the extra manipulation that I'll need to do for DMEC is going to result in more endothelial cell loss, rather than do a quick, easy DSEC, which will result in less endothelial cell loss. I think is the second scenario. I think in those cases, DSEC do better as well as compared to DMEC. Third is where I expect there to be a challenge with maintaining air bubble inside the anterior chamber. Somebody with a vitrectomized eye where I can't maintain position and things like that, I think is the third scenario I wouldn't do DMEC. I would do a DSEC. Earlier, when DMEC came about, people thought, oh, DSEC is going to disappear, but that's not true. DSEC very much has its place and probably is better than DMEC in some scenarios like this.
Shreyash, on to you.
Wonderful, sir. I mean, beautifully summarized, and I think the situations, the videos, it was truly entertaining and lovely to watch as always. Quick question, sir, regarding the sizing that you did in some of these cases where you released all the Synechae. I mean, it was very nice to watch, but very often these Synechae do tend to come back. And while it may not really pull off a DSEC graft with a DMEC, that might be a little bit more of a concern. Would you really undersize the DMEC graft in those sites?
I mean, that's a great question. And interestingly, I just want to show you a quick slide because what we did was we, in fact, published this in Corneal, I think last year, 2 years ago, with the hypothesis that DMEC potentially prevents Synechae from coming back as compared to DSEC. And this is the same patient that I showed you today over a 4-year period of follow-up. And you'll see that there is some distortion of the pupil that is happening and some peripheral Synechae, but the majority of the Synechae actually have not come back. And so the hypothesis that we put together in the paper was because eye syndrome is also abnormal endothelium that grows, epithelioid kind of transformation that grows on the iris and on the angle and the cornea and causes the Synechae. If you have good endothelial cell counts and your DMEC graft endothelium actually migrates peripherally, then that probably will prevent the influx of this epithelial endothelium towards the center and maybe retard Synechae. Because we don't see that with DSEC. DSEC also Synechae form very quickly, but it seems that DMEC might have some mechanism in preventing Synechae from developing.
So does this apply only for eye syndrome, or you would do it even for a failed graft with peripheral anterior Synechae?
I don't know if it actually works for those scenarios. For eye syndrome, it seems to be pretty predictable, but others I'm not very sure about.
Wonderful, sir.
Thanks, Shreyas. Nice to see you.
Any other questions
Yes, sir.
want to have we brought out relevant to this talk? I think we are all spellbound, I think.
We are all hungry.
So actually, we were intelligent and we are finishing it half an hour before time.
Amazing.
That's fine. That's fine. Just fine. So I think I'll conclude and thank you so much, all of you, for this, your patience, dear expert panel, for being with us and such a lot of energy. Like I knew for varied reasons, This time, some of our speakers had to move away because of the other commitments. But then it is a very lively discussion and there's so much of learning. I'm sure this thing would be viewed by people again and again on the YouTube, and that's how enriching this webinar has been. Thank you so much. Thanks a ton. Have a great day ahead. Thank you.
Thank you. Thank you so much, sir. Thank you.
Thank you.